This is Tony Windling. My research proposal is on the effect of timing on blood pressure assessment in ambulatory care clinics. The background for my study: high blood pressure is prevalent among adults. 30% of adults have been identified with blood pressure greater than 140 over 90 millimeters of mercury, the definition of high blood pressure. There are no early symptoms with high blood pressure. Therefore, it could be left untreated, and high blood pressure left untreated leads to disease of the heart, the kidneys, and the vascular system. In addition, blood pressure in clinic measurements is often unnaturally high. The reason for the unnaturally high blood pressures have to do with adherence. Office practices do not consistently follow American Heart Association or United States Preventive Service Task Force recommendations. Reasons for the blood pressures in clinics being abnormally high. According to the literature, there's a lack of knowledge in practices. So in this study that cited, current practices acknowledged that they knew the right way to take a blood pressure as little as 57.5% of the time up to 93.5% of the time in the different clinic practices that were studied. And then there's also a lack of adherence even when practices know how to correctly assess blood pressure, both by staff and by physicians. There's a concern with the cost of obtaining an ambulatory blood pressure monitor test to confirm a diagnosis of high blood pressure, and in some cases there's a lack of availability to get the equipment to do an ambulatory blood pressure monitor for confirmation of a diagnosis. And finally, there is a white coat effect on blood pressure where the presence of a clinician leads a patient to have a blood pressure that's higher than it would normally be outside of the clinic setting. The conceptual framework that I'm using for this research proposal is the Newman's systems model, where the patient is seen as a component of a system that is in constant exchange with the environment, and the presence of stressors in the environment contribute to a patient's response to their environment. The purpose of this study is to determine if a blood pressure measured at the end of the process of checking a patient into the ambulatory exam room results in a statistically lower reading than one taken immediately after calling the patient from the waiting room. This design is a retrospective observational study. It's based on some actual work that's being done in the ambulatory clinic right now. We had a past practice, and we'll be comparing that to new practice as it relates to blood pressure measurement. I've called past practice workflow number 1, where blood pressure was taken soon after a patient was called from the waiting room. And workflow number 2 is new practice, where we instituted standard rooming in our clinics in March of 2017, and blood pressures are taken at the end of the rooming process. There's an estimated average time lapse of about 14 minutes from calling a patient from the waiting room to the completion of the rooming process. So the data collection will be from chart review of patients seen in 5 selected primary care practices, 2 in family medicine and 3 in internal medicine, all at Stormontvale Health in Topeka. The patients must have had a billed office visit, evaluation and management codes 99213 to 99215, both prior to and post intervention, so from March 2016 through February 2018. Blood pressures will be collected and reported only once for this data set, even if a patient's been in more than once. So data will be sorted first by the medical record number and then by date. And then data from the first visit by date, both pre and post intervention, will be included in the study, and other MRN data will be discarded. So for instance, if a patient's seen 3 times before the intervention and twice after, we will sort the data by MRN and then by date, and use the first date data and get rid of data from visits 2 and 3 pre-intervention and visit 2 post-intervention. Data will be extracted from discrete data fields in the EMR and collected utilizing reporting capabilities that we know that we have in the EMR. but the report after configured will be validated by a manual chart review, and I will select at least 50 random cases at a minimum to do a manual chart review to check the accuracy of the data collection. The data points collected will be the patient age, sex, race, body mass index, and smoking status, systolic and diastolic blood pressure values. And I will also include patients from the study who have on their problem list diagnoses one or more of the following: hypertension, chronic kidney disease, diabetes mellitus type 1 or 2, and or heart failure. And that will be determined using Medicare groupers that we use for other reporting capabilities. So we will evaluate pre- and post-intervention populations for homogeneity to identify for confounding variables. I really expect a fairly homogeneous pre- and post population due to the fact that it's going to be a large data set, and I'll be collecting the pre and the post data over approximately the same number of months and times of year, starting and ending the data collection. I'll do a t-test assessment of the mean blood pressures pre and post intervention and accept a median effect. So significance would be determined as a mean systolic difference greater than or equal to 10 millimeters of mercury and a mean diastolic difference greater than or equal to 4 millimeters of mercury. There'll be a power of 80%, so we'll accept a 20% risk of a type 2 false positive, and the level of significance will be 5%. There's no active recruitment of study subjects for this study. It will be a convenient sample, and that will be determined by the number of patients that fit the inclusion criteria of that qualifying visit over the 2-year study period that I mentioned earlier, based on those E&M codes. We will exclude criteria and the patient, if they're less than 18 years old when the study commences, they're excluded. If there was a presence of a billed procedure code along with that E&M code, I wouldn't want to include a patient who has had a procedure at the same time that they're having their blood pressure evaluated, because the stress of having the procedure may affect the blood pressure. And E&M codes from the first 2 full weeks of March will be excluded, because that's when we're doing the standard teaching, and I can't be sure who would specifically be pre and post intervention at that time. So the risks and benefits. Benefits to the study participants would be if the significant mean decrease in the recorded systolic, diastolic, or both pressures is there, then patients may not have received unneeded medications or further testing for elevated blood pressures. And future patients, if there's more accurate assessment of blood pressures, they'll have a better blood pressure by which physicians can devise treatment plans. And risk, there's no greater risk in terms of discomfort or inconvenience or altered treatment between either of those workflows. The consent for this, the human subject study requires approval by the Institutional Review Board, but it doesn't require written informed consent because we're using archival data. And information collected will be de-identified, so once the report has been created by the EMR query, then we'll remove the MRNs and just process the data. And here's my references.